into the occult kind of synchronous hypothesis and some of the published literature around this potential origin of these rapidly recurrent metastatic lesions. I think one of the really important things to understand about pancreatic cancer that I think is a difference in paradigm in the way that we think about a lot of malignancies is that we can identify markers of carcinogenesis and metastasis and dissemination in these lesions, at least in preclinical models, prior to having tumors form that are detectable. This is a really elegant paper out of Ben Stanger's group, oncologist Andy Rim, who worked with the KPC mouse model, tagging these with a YFP reporter, and essentially showing that in early pannin lesions, as you'll see in panel M here, early pannins in the liver, and mice that only had pannin lesions, you could identify YFP positive cells in these mouse livers, indicating that cells at a pannin stage are learning or are developing characteristics that allow them to disseminate. We can argue a little bit about whether these have the potential to develop into fully fledged tumors if they colonize the liver. But I think what this reflects is the possibility, at least, that these primary tumor cells can shed prior to becoming invasive tumors and can be found in the circulation at takedown, which you see in this graph here in these mice, but also can be found as resident cells in the liver. Laura Wood's group and Ashley Kyman at Hopkins also have recently published some really elegant work making spatial landscapes using this technique they developed called CODA, which models multiple layers of tumors through H&Es and is able to kind of develop a 3D structure of these tumors and of the precursor lesions, in fact. And they sequenced through 36 or 37, 38 rather, 38 primary pancreatic specimens. And these were non-tumor specimens, adjacent normal tissue, looking at the characteristics of the tumor-adjacent pannin lesions. And one of the really jarring things that they found here in looking at these structures, in microdissecting some of these tumors and doing some spatial transcriptomics on these pannin precursor lesions adjacent to these tumors, was that the mutational profiles of these precursors, of these pannins, were really diverse. So a large diversity of kind of canonical mutations, and also so these geographically distinct lesions, and many of them kind of forming in this tissue. So this, to me, I think underscores a bit of a paradigm shift in how we think about the pancreas, how we think about the possibility that different tumors can arise, and how we need to kind of think about intercepting this disease and intercepting metastasis in these lesions. One of the really, I think, striking findings here as well was that within these pannins, we had a whole array of KRAS mutations as well, and so a big diversity of precursor lesions and potential mutations in kind of these premalignant regions. If we move then from kind of this idea that these potentially could be occult synchronous lesions to a more seeded metachronous hypothesis, I think there's also good evidence for this being a source of these metastases as well. And this is from Ralph Rubin's group, also working with Laura Wood at Hopkins, looking at kind of the distribution of tumor within the blood vessels around pancreatic tumors. And essentially, you're seeing these peninsulas of carcinoma that are growing within small venules that eventually coalesce to become SMV or portal vein, but basically have a direct route to the liver. And you can imagine with a procedure kind of as physical as a pancreatic duodenectomy, having a metastasis competent clone of these cells embolize and to pick up a spot in some portion of the liver at resection. And there's some reasonable evidence for this potentially being one of the ways that we can move the needle in pancreatic cancer. So there was a group in China a couple of years ago that was working on a no-touch technique for pancreatic resections, essentially. And there's some Japanese publications as well looking at a vein-first resection approach for the pancreatectomies. I think some of the challenges that we face just in being able to get someone technically to an operation makes some of these approaches impossible, but I think it underscores some of the difficulty and realities and reasons why we are not making many improvements in the treatment of pancreatic cancer. And again, I think this reflects something that we need to think a little bit more deeply about. Another group kind of working on a no-touch technique, I think this was out of UCLA, also showed that kind of the number of circulating tumor cells that you could identify in the portal vein was much lower in patients with a lower touch technique, at least providing some support to the idea that potentially minimally invasive surgeries or minimally invasive approach when possible, or considering these possibilities might be important for providing more effective surgeries or more effective treatments for these patients. So I think the likelihood is that there's some possibility that rapid metastatic recurrence in pancreatic cancer actually comes from both of these origins in different patients. And I think what's important is to look at what metastatic paradigms pancreatic cancer metastases fit. I think when we conceptualize how metastasis occurs, we think that cells within the pancreas or within a primary tumor or a site of origin will develop some degree of mutations, and they kind of progress along this linear fashion to develop additional driver mutations and gain additional features, and then kind of through evolutionary fitness are ultimately able to break through basement membranes, break through vessels and erode and then enter circulation or enter lymphatics and metastasize to distant organs. This is a nice review on breast cancer metastasis from 2009, but I think it's also pretty critical to apply to pancreatic cancer and all malignancies, as well as we're kind of thinking about how we know what we actually know about where pancreatic cancer metastases come from and why we see them kind of in the kinetics that we do. I think what's much more likely in pancreatic cancer and in a number of malignancies is a more parallel progression model where clones of cells are potentially developing in multiple locations and developing different abilities to metastasize. And we have to think more that metastasis is probably, I mean, we know that metastasis is a process that's happening constantly with these tumors, and that survival in the circulation, colonization of distant organs, being able to survive and evade the immune system are all really challenging events for cells. Is there a question? Oh, sorry. And we see with these varying degrees of latency, at least in breast cancer, that this likely is the case. I think a nice study in pancreatic cancer that illustrates this is an autopsy study from 2020 that looked at primary tumor resections that had been treated with adjuvant therapy, and then followed and sequenced their metastatic lesions, and were able to develop these phylogenies that support both modes of metastatic dissemination in pancreatic cancer. Interestingly, in this top top dendrogram, you can see that the primary tumor has kind of these originating mutations, but that subsequently the local recurrence and the liver recurrence seem to arise from cells that recurred along the same lineage. Whereas in C, you see that the primary tumor mutation is much farther along than some of these other, much deeper in this phylogenetic tree than these other mutations that occur both in lymph nodes, but also in the local recurrences and liver metastases as well. And in modeling this group showed essentially that even some local recurrences that you can see in this panel at this pancreatic ojejunostomy were derived or were downstream evolutionarily from a liver metastasis. And so you can have lesions that metastasize from a liver metastasis to the lung, or a lung to pancreas. And I think, again, this reflects really the nonlinear nature of metastasis in pancreatic cancer, and how we need to kind of think about both designing studies and treating and intercepting this disease. I'm going to shift gears a little bit to the scope of rapid recurrence clinically, and really the evidence for why this is a persistent problem and not something that is sort of one-off or anecdotal or rare. This occurs essentially in a number of series at rates of about 15 to 40%. These are all retrospective reviews looking at details of pancreatic cancer recurrences within 6 to 12 months after resection, and essentially looked at different clinical features, but showed that this is happening at a rate of about 20 to 30% in these cases. We looked at our own data over the last 20 years. This is a paper one of my residents, Ranish Patel, published a few years ago. And we essentially showed that even over the advent of neoadjuvant chemotherapy in the mid-2000s, the addition of kind of FOLFIRINOX as a regimen, more aggressive resections, improved cross-sectional imaging, so the increasing use of MRI, but also the use of multiphasic CT in these patients, that we see essentially a flat line of recurrence rates of about 20 to 30% over the last 20 years. And this is a Portland-wide metro database, community centers, academic centers across the city, comprising about 900 patients. And Renee showed that recurrence is pretty critical in these patients, because after patients recur, their survival curves essentially align. One of the only clinically relevant features that we saw that made a difference across these groups was the receipt of adjuvant chemotherapy. I think a lot of the rationale that we have, and we're going to get into this a little bit as we start to move into what my lab is researching, is that these recurrences tend to occur in patients who don't receive adjuvant therapy, and that there's really no difference across the receipt of neoadjuvant therapy in these patients as well. So, you know, one of the main rationale for delivering neoadjuvant chemotherapy in these patients is to try to avoid having metastatic failures and to control for potentially micrometastatic disease or treat micrometastatic disease in these patients. And so one of the questions we have is, again, in this retrospective data set, why this might be occurring and why we might be seeing this as some signal for the biology of these metastatic lesions. So our group has been working on modeling this and using really kind of a large set of resected pancreatic tumors at the Brendan Colson Center for Pancreatic Care here, where we have sequenced over 300 primary tumor resection specimens, looking at whether there's some feature of the primary tumor that we might be able to leverage for predicting which patients, based on biopsies, based on their sequencing, are more likely to have these recurrences. And part of the issue, despite having a lot of primary tumors to sequence, is that what we don't have is a lot of metastatic tissue. And what we also don't have are early metastatic lesions in human livers to be able to investigate what's going on with these micrometastatic lesions, or what is happening in terms of the immune microenvironment and tumor control or not, that might be impacting rates of recurrence in this patient population. This is some gene set enrichment in a comparison of our rapid metastatic recurrence cohort versus those who didn't have recurrences. And this is not in that 900 patient data set. This is now in that 300 patient subset, where we have approximately 60 patients who have rapid recurrences or a liver-only metastatic recurrence within 6 months of their surgery. We compared those to patients who did not have recurrences at 24 months. And so they had to have good cross-sectional imaging up to 24 months.
ที่เรา reference หมดเลยอะ
But to be able
ใช่
to
ใช่ไม่ใช่เรื่อยๆเกือบทุกเคส
someone might be
ไม่มันเป็นตัวโรคแหละค่ะมันไม่ค่อยดีอยู่แล้ว
Sorry, someone
Oh,
please
I got
mute
it.
microphone ค่ะ
I think I can meet people. That's great. Essentially, what we saw was that there are some transcriptional differences in these tumors. There's both an increased inflammatory response within the primary tumor sequencing themselves. There's also increased mTOR signaling, increased glycolytic pathways. And so there are some tumor intrinsic differences that occur, but nothing that seemed like a dramatic slam dunk identification of what anything particularly tumor intrinsic that we could identify here. We then performed some single cell profiling of the immune composition of these tumors, and essentially showed that rapid recurrences had much fewer epithelial and tumor cells that were able to be identified here as well. And some of this is thought to be related to processing of these specimens, but I think this was kind of an interesting feature that shows that there's some degree of immunologic differences in these tumors. We took this to a TMA of these sequenced specimens as well, and found that there are some differences in the fibroblast population in patients who have these recurrences. So potentially some tumor intrinsic differences as compared to those patients who have a longer term non-recurrence as well. So certainly some tumor intrinsic factors that may be related to this that we are still in the process of investigating. So we wanted to ask also whether we could model rapid recurrences in vivo and be able to collect more tissue for preclinical studies, for translational investigations into these analyses as well. And so for many years, we had used ultrasound as a mode of trying to identify in vivo metastatic lesions in our mouse models. We've ultimately moved to a micro CT scanner, a rapid kind of in vivo micro CT scanner that gives us really nice resolution into liver metastases. And we can actually get to a resolution with higher degrees of higher power radiation in some of these of 50 microns per voxel in these. And so a really nice way to kind of detect and identify early on metastatic lesions in our mouse model, which I'll go into in a moment. We've also been able to identify circulating tumor cells kind of in this novel technique of portal vein exsanguination in our mouse model. And so we wanted to identify in our mice whether surgical intervention would accelerate metastatic outgrowth in these mice. And so we moved into an orthotopic model where we inject about 5,000 pancreatic cancer cells derived from this mouse background. So they're injected into mice that are immune competent, which was critical for our model. And this is a part of a mouse model that we developed in Rosie Sears' lab, and that she has been working on for many years, that we're now in the final stages of review and publishing this model. And so we're waiting to get that paper out before publishing some of this work so we can use the model in our publication, but we're very excited about that. But essentially we use these lines that leverage kind of these early KRAS mutations rather than KRAS and P53, which is kind of an early mutation and a really late event in pancreatic tumorigenesis. If you recall, the slides I showed a few back, looking at the really nice cross-sectional imaging and CODA technique that had been used to profile pannins in the region of non-tumor pancreas, that group found that of those 38 sequenced tumors, P53 mutations were only present in one of the pannins that they identified. And so when we use a KPC model, which is kind of the gold standard for preclinical studies, we're really modeling pancreas tumors that have really the early and late mutations that are commonly seen in human pancreatic cancer. And we think the problem with that is that, as you'll recall, the early dissemination seen in pannins doesn't occur necessarily with the same types of mutations. And so looking at kind of the early events in pancreatic tumorigenesis and the early events in metastasis, we feel was something difficult to do with the KPC model, which is highly metastatic, but again, driving two kind of very disparate mutations. And so using this KRAS mutant MYC model that we've developed, we found that we've been able to model metastasis in pancreatic cancer really effectively. So essentially what we do in this mouse model is do an orthotopic injection into the pancreas. We let these tumors grow for about 14 days. We track them with ultrasound over that period, and then we cohort the mice based on their tumor growth and based on tumor size. So those are even across the cohorts into resection. So they'll get a mini laparotomy, as you can see in this panel here. We're able to externalize the tumor, resect that from the mouse pancreas, and then pop that back in the abdomen. And mice do quite well with these surgeries. So we have a resectional model. We also have a sham surgery wherein we give the mice tumors, but also put them under anesthesia and just open the abdomen and then close again. So there's no manipulation of the tumor. It's just meant to mimic the stress and kind of neurohormonal stimulation associated with surgery. And we also have just a control group where they get the tumor injection and no surgery. We ultrasound these mice 2 to 3 times a week, or CT them 2 to 3 times a week, and essentially follow them for development of liver metastases. And what you'll see here, this is at day 0, which is the day of resection. They've had 2 weeks of growth prior to this, and then they have tumor resection. We'll follow their livers, but this pink line is our distal pancreatectomy group, and we're able to reliably identify metastases in the mouse livers radiographically and microscopically by day 7, median of day 7 after resection. The same holds true, and we were surprised to find this with sham resections. And so this indicates that at least in this model, potentially what we're seeing is not necessarily dissemination because of tumor manipulation per se, but potentially acceleration of metastatic outgrowth because of the stimulation of surgery. We follow the control mice as well and find that while there are some that develop metastases around day 14, that our median development of clinically evident liver metastases takes another 7 to 10 days compared to the surgically stimulated mice. We're going to shift into kind of our hypothesis around this and some of the work that we're developing to investigate this further, both with some future grant work, taking this into our human population and investigating what might be mechanistically causing this. But we treated some mice with DNAs as well. And I'll come back to this slide in a moment to kind of show this, but the DNase treatment we find, at least in early numbers, seems to abrogate the accelerated effect of metastasis that we see in the mice that just have surgery. So we've investigated the primary tumor. We've looked quite a bit at the tumor microenvironment and cells around the primary tumor. Our next question really was what might be happening in the liver. And there's a whole body of literature around the transcriptional changes that take place and the changes that take place in the metastatic microenvironment that can influence tumor colonization, development, and outgrowth. But that has really focused on exosomes. It's focused on the crosstalk of the primary tumor and the liver as a metastatic microenvironment or hepatocytes, but doesn't specifically look at what changes around surgery and stimulation from surgery might happen in really the largest metabolic organ in the body. And so this is some work that Gustavo Salgado, one of our research residents, now one of our surgery residents, did with me in the lab. And essentially, we asked the question of whether transcriptional profiles changed within the liver in a way that would help us identify whether or not a patient was going to develop rapid recurrence after their pancreatic surgery. So we started taking opening biopsies of liver parenchyma. This was kind of a 3 millimeter core skin punch biopsy, essentially. And we would take that at kind of opening, so as immediately as we could at the beginning of surgery. And then after tumor resection or around closing, and this was on average about 6 hours after the initial biopsy, we would take a closing biopsy. And we would do this in the same liver segment, but far enough away to avoid any bias or local changes from the wounding caused from the initial biopsy as well. What we found, interestingly, in doing some GSVA and volcano plots looking at differential sequencing across these lesions, was that were a number of signals that were elevated for neutrophil extracellular trap deposition. And neutrophil extracellular traps are a component of the innate immune system. It's essentially the disgorgement of chromatin and matrix metalloproteinases, different histones that neutrophils will kind of expel in response to different PAMPs and toll-like receptors and other kind of innate stimulants of the innate immune system, and found that we were seeing a real uptick in the signal of neutrophil extracellular trap gene signatures, in addition to a number of other neutrophil signatures, infectious neutrophil signatures that are also related to NET production and development. And NETs have been implicated in colorectal cancer and a number of other malignancies with some really nice work that Alan Sung did in circulating tumor cells and the potential of circulating tumor cells to be able to develop and grow into metastases. But what we were seeing here were signatures within the liver parenchyma itself. And so essentially we took the other portion, we had divided these liver biopsies, and we took the other portion of the liver biopsy that we had fixed and did some IHC and immunofluorescence to look at whether we were seeing increased NET deposition within the liver parenchyma. And so you can see in these opening biopsies, this is an antibody for Ly6G, which is a neutrophil marker. You see these resident neutrophils within the liver at opening, so quite a lot in some patients. Some of these patients will have some degree of biliary obstruction or cholangitis or other inflammatory conditions. Some of these patients have kind of smaller amounts of resident neutrophils, but what we saw relatively universally, and we're still in the process of quantifying, this is pretty new data, is that across surgery, we would see deposition or of chromatin. This is citrullinated histone H3, so it's one of the histone proteins that kind of coils DNA and helps it turn into chromosomes, chromatin. We were seeing these increasingly throughout the liver parenchyma across surgery. And so the focus of much of the next few grant cycles in our work now is on this hypothesis that surgical intervention is causing some organ-wide stimulation of NET deposition in the liver parenchyma, and that this has been shown to activate dormant cancer cells in lung cancer and in the Lewy lung carcinoma model of rat model of lung adenocarcinoma, and that the metalloproteinases and different proteolytic enzymes that are secreted with these histones or with this NET deposition actually causes matrix remodeling around these disseminated dormant cancer cells. As we talked about earlier, the challenges that cancer cells face in being able to exist and reside in a metastatic environment are challenging. We know that disseminated cancer cells will enter some degree of dormancy. This actually probably helps them evade immune surveillance locally as well. And so our investigations now are around whether this NET deposition in pancreatic cancer patients' livers is stimulating exit from dormancy in these disseminated cancer cells. And so we've got a nice model for surgically accelerating metastasis. We've got a nice model for identifying disseminated single cancer cells in the liver of our model. And now we're working on kind of connecting these mechanistically to investigate this a bit further. So I hope I've convinced you that rapid recurrence is a real phenomenon, a distinct and persistent clinical entity that shouldn't just be approached with some of the nihilism that we approach pancreatic cancer with, but that needs to be understood mechanistically in order to intercept it and achieve better outcomes for our patients. I'm hopeful that we can translate this in the coming years to more targeted investigations in patients who experience rapid metastatic recurrence in pancreatic cancer, but also into understanding how the timing and sequencing of our therapies around both a neoadjuvant and adjuvant approach to pancreatic cancer might influence some of these populations of cells. I like to tell trainees that metastasis does not necessarily equal metastasis, doesn't equal metastasis, that there are a number of modes of metastatic outgrowth and control involved, and this is really a prime problem to apply to a lab run by a surgeon where we're investigating these problems. I couldn't do any of this work without the really excellent help from Maka Vergara, who's my senior research associate and lab manager, Emma Ritchie, one of our research residents, and Gustavo Salgado. And I'm happy to take any questions at this point.
Thank you very much, Dr. Worth. Dr. Thirawood, do you have any question? Okay, I like to ask around various groups. Dr. Ton, do you have any question for him? Quite advanced talk today. So, Dr. Vinita, you have a question?
Maybe Dr. Chun has his hand up.
Hello,
Okay.
I'm Dr. Tan from Bangkok Hospital. Thank you very much for your wonderful talk. So I have a few questions about, as I'm a pancreatic surgeon also, and we also concerned about the recurrence, the early recurrence that you also experience. For the preoperative evaluation, do you always do the PET-CT just to make sure there's no micrometastasis?
Great
So that's,
question.
yeah.
Yeah, I
And
think, oh, go ahead. I'm sorry. Please go ahead.
So, I'm sorry. So my second question is, do you always do the neoadjuvant or you prefer the surgery first in the resectable case? Thank you.
Great. Yeah, really, yeah, not controversial at all. That's wonderful. So, there have been a number of trials, smaller trials that have looked at multi-phase CT versus MRI, as opposed to kind of maybe a PET, but MRI in pancreatic cancer, and for by and large, those have not really shown major differences in being able to detect and intercept micrometastatic disease. We don't routinely get PET scans in our patient population. I think in this specific population, we would be looking for something that's probably under the resolution limit for the half centimeter size that would be necessary to see some of these micromets. So, while I think that we need to really kind of think about pancreatic cancer as a systemic disease and something that's probably metastatic and systemic, even in the patients that we think are upfront resectable, I don't know that our current cross-sectional imaging modalities are going to help us with this particular problem. Maybe, I think a question I get a lot is why aren't we getting MRIs? Why aren't we getting PET MRIs on a lot of these patients? And we haven't really done. I'm interested in doing some of the kind of cost benefit analyses that would be necessary to kind of detect these and what the cost of the healthcare system in the U.S. would be trying to get an MRI on all these patients. At least at OHSU we would be delaying patients by weeks and maybe even months to if they all needed to have an MRI prior to their workup. So it's how we detect these, how we try to convince ourselves that metastases are not there or cells with metastatic potential are not there, I think is really challenging. Your second question, I think, I think we don't know yet with upfront resectable tumors. I've seen a lot of mixed data, and to me, the kind of the best conducted trials are all out of Dutch or Scandinavian centers where these big centralized systems are able to capture kind of this large group of patients. They have really excellent follow-up, and one of the, I think, was it the NORPACT trial, had an adjuvant receipt rate of like 86 to 90%, which is absolutely not where we get even near close to in our patient population. So I think there's a role for neoadjuvant therapy. I think I err on the side of neoadjuvant therapy, even in upfront resectable patients, for a variety of reasons. I think there's a possibility that in some of this subset of patients with rapid recurrences, if these are dormant cancer cells, our cytotoxic chemotherapies like FOLFIRINOX, gemcitabine, are reliant on these tumor cells being active and dividing to be of any use. And not that they're that effective against primary tumors anyway. So I think we might be missing the boat a little bit, assuming that a neoadjuvant approach is going to get rid of this early recurrence phenomenon. In fact, it hasn't. We see that in retrospective data. Excuse me. We also, if you look at the survival curves too from a lot of these borderline or upfront resectable trials, most of the benefit is not seen in the early 6 to 12 month period. Pre-Panc's improved survival of 14% was way out at, I think it was 59 months or something like that was the median. Way out. And so I think a perioperative approach is probably going to be important. I think a lot of what we need to do also, and part of my interest clinically, is trying to improve the recovery patients have from surgery, improve leak rates, improve kind of all the morbidity from pancreatic surgery, so that we can get more people to adjuvant therapy. Because I think if we are stimulating this micrometastatic disease, even if it's not dormant, even if it's just a cult, or stimulating this disease, I think there's still going to be some benefit to adjuvant therapy in these patients. So I think it's we're going to have to make little incremental improvements across the treatment spectrum in pancreatic cancer, whether it's improved therapies or improved outcomes or decreased complications or better understanding of the biology.
Thank you very much for your answer. So I would like to share my surgical practice experience. So I think it's too difficult to make the final conclusion that you will go for neoadjuvant 100% or sometimes it's surgery first. So it depends. But the thing that we already concerned also in your topic, that the early recurrence, that maybe it's a micrometastasis that we cannot detect it. So I think I'm fortunate that at Bangkok Hospital, we have PET-CT. So we prefer to send the patient if they able to pay for it. And we can screen some patient out that is not suitable for proceed surgery. So that's the first thing. About the neoadjuvant, I'm kind of relying on to the neoadjuvant side, but there still be some group of patients, some selected patients that, is clearly resectable, small tumor, there will be some benefit. But as we know that when you do surgery, especially like whip operation or even distal panc, so you may need a little time to recover or from the surgery. And then I think my shortest time is like 3 weeks or 4 weeks before we start systemic treatment. So I think that one is the period that I concern after surgery, that as you show in your slide, in the first few slides, that in the 1 or 2 months after surgery that you find recurrence, and you're not happy that we might choose the wrong patient, right? So thank you very much for your lecture, and I think there will be something that from your lab result that can improving about how to choose the patient about the recurrence, or even some systemic therapy regimen. Thank you.
I hope so. Yeah, thank you.
Thank you, Dr. Tan. Ka. We have one last question. Can be done in 4 minutes. Anyone? Okay. If not, thank you, Dr. Worth, for your very advanced lecture this morning. And we hope to see you again in the future. Thank you, Dr. Liana and the team, for your kindness. Thank you.
Thank you very
Thank
much.
you so much for your attention. Yeah, it was a
สวัสดี
pleasure.
ครับ
Hey, Patrick. Did you hear me?
Yeah, I can hear you. Hi.
Hey, I have a question for you.
Oh yeah, go ahead.
With this like research that you have done, I mean, it's very hard not to argue for neoadjuvant for everybody. Even if you don't know, I mean, clearly you don't have the right chemotherapy agents. If you're telling me it's such a multiclonal disease and you're giving them one that kills all, supposedly, I mean, you're showing me panais like special in the pancreas with a different molecular profile.
Yeah.
I mean, if we don't want to be all pessimistic, I would say neoadjuvant therapy in all pancreatic cancers, how much you think, oh, this is a cheap shot, Whipple, it needs to happen. It's kind
You
of a
know,
hard argument not to make, even if you don't have the best chemotherapy drugs. I don't know if Adele is still here, but I find this fascinating because in colon cancer, I mean, it's a multiclonal disease, but our surgeries are not that morbid. In
yeah.
Whipple's, the surgery is so morbid, like it's a no-brainer. Not to say we should do neoadjuvant.
I tend to agree with you. I think the I I think the problem we get into also is that some people will get, 3 or 4 cycles pre-op, and then they have the resection. And I think that there's probably some real benefit to adjuvant therapy as well, just based on maybe just in this population. But for some of the stimulation that we may cause in dormant disease or something like that, I mean, I don't know. I think we tend to oversimplify the treatment of this a little bit simply because it's a very morbid cancer, but it's still relatively small numbers. I mean, it's just pretty fatal. So, and it's in these older patients. So these trials rapidly become kind of less applicable to other patient populations very quickly, and so I don't know. I tend to agree with you, and I think neoadjuvant makes a lot of sense, but we'll see.
And the other question I had, how often or what is the percentage of that rapid recurrence within pancreatic cancer? Or I would say more likely it's there and we cannot see it. Like what, because they're not all pancreatic cancers, as you said, the same. Like what would you say the recurrence of the percentage of that would be?
In resected patients, it's 25%.
25%. Okay.
20 to 30% over the last 20 years in Portland, but there are some series that go up to 40% in these retrospective series. But yeah, it's high.
It's high, which makes even more the argument of neoadjuvant therapy.
Yeah.
It makes it like kind of a no-brainer. I'm not saying that I have the right drug, but that's all I know. And as we improve, then it may become more like more of a must than discussion in a multidisciplinary tumor board. It was fascinating. I cannot thank you enough.
Oh, my
I see some people have stayed already. I thought we were having this talk, just the two of us. Anyway, thank you, Patrick, so much.
My pleasure. Thank you.
Have a good night.
You too.
Bye-bye.